Welcome, welcome. Welcome to
Oh,
Catalyst Conversations. I'm super psyched for our first session, our pilot today. Your hosts, Johnny and I, have wanted to put something together in the innovation space for some time. We've both been involved in supporting research based ventures. And so the idea of Catalyst Conversations is really to build a community of like minded individuals interested in learning more about the problems of our world from a research perspective and being introduced to teams and ventures who are working on commercial solutions. And rather than just doing another podcast, we want the sessions to be actionable for our members, providing opportunities for you to get involved with the topics of interest and with the teams that will come to our show. Our guiding principle for these shows will be that it's easygoing, as you saw, engaging, and to the point. Johnny, do you want to share how these sessions will work?
absolutely. Yeah, a warm welcome to everyone from my side as well. Welcome to the first episode. And without further ado, we're going to very briefly explain how every episode will be structured. So, we would like to cover a specific topic or industry every time that we're streaming. And there will always be at least one invited guest who's a disruptor in this industry that we would want to have a conversation with, and this guest will sit down with us. Um, Firstly, we will start with a topical deep dive with a subject expert or experts. For example, today we have two, so there could be always more than one. Stay tuned. We're going to check out the status quo, explore what the industry is, share some stats and facts, and this will be in the form of a conversation with a guest. And then after we've explored about the industry, the guest or the guests will do a 10-minute pitch of their startup, sharing their vision, how they plan to disrupt this industry. And of course, afterwards, as Roman mentioned, we will really want to focus on the community engagement part. So we're going to have a live Q&A with all of you after the pitch. There will be a specific forum in our community in Discord where we'll have the founders, and this episode will be which will be recorded will be put there where you can all ask questions about the industry or about the solution or about the startup that our guests are talking about.
Cool, Johnny.
Yeah.
So, what's the topic today?
So, topic today, as our first episode, we want to start with something that makes us very happy, uh, or no, right? We're actually talking about depression today, Roman,
Oof,
right?
that is a big topic and no doubt a big problem as well. Uh, Johnny, do you have any exposure to this? I personally don't.
Not really. However, we can very often see people close to us that could suffer, especially in the social media, where we see a lot of people talk about it. Makes me wonder. What about you? Do you wonder, even though you might not see it? Do you
Well,
wonder?
look, yeah, I think life is a gift, and I have the impression that people with depression, they are basically not really living their life. And my intuition, we're going to find out now in a minute, is that this problem is very prevalent and quite possibly actually becoming bigger, over time. I'll be very, very curious to actually hear from our speakers today, who I think are true experts in the field. But before we introduce the speakers, Johnny, do you have a definition of what depression actually means?
Yeah, I was like while you were talking, I looked at this AI generated child we have here in front of us and found a video as well that I think can explain it much better than me. Let me try to put it up. Uh,
It is estimated that 5% of adults experience depression. But because it is a mental illness, it is a little bit harder to understand than, let's say, having a cold. The key is to separate out depression from occasional feelings of sadness or stress. Almost everyone feels down once in a while, like when losing a job, having an argument, or even witnessing a stretch of bad weather. However, these feelings come and go. They respond to ongoing changes, while depression tends to feel heavy and constant. At times, it can be difficult to identify depression in someone, as it is a disorder defined by thoughts, behaviors, and feelings. But there are some common symptoms of depression, such as prolonged periods of having no motivation or interest in things, changes in appetite, feeling worthless or guilty, sleeping either too much or too little, low energy, and difficulty concentrating, avoiding social interactions, or recurring thoughts of self-harm or death. Those who have experienced depression might have heard comments like, "Snap out of it," "Brighten up already," "Go and do something about it." However, it is important to remember that depression is a disorder with a biological basis, along with psychological and social implications. It is not simply a weakness that somebody can get over or laziness that one can shrug off. Depression seldom gets better without treatment and may get even worse. Fortunately, there are many different ways of treating depression, such as therapy, medication, lifestyle changes, joining a support group, or at times, simply confiding in a trusted friend or a family member. Although there is no quick fix for depression, the effort is completely worth it. And you may come out of it perhaps even stronger. For more information on depression, as well as treatment options, please visit www.psychiatry.org.
And of course, we're going to do a shout out to www.psychiatry.org, I guess, with this video. What do you think, Roman?
Yeah, complicated problem. I suggest let's introduce our experts. They'll know a lot more about this than we do.
Absolutely, right. Without further ado, it's my pleasure to introduce our two guests of the day, Matteo De Bardecci and Sebastian Olbrich. They're both working on something very cool, but most importantly, Matteo is a data scientist in psychiatric research. He is a full-fledged ETH student, did bachelor's and master's at ETH, bachelor in physics, and a master in biomedical engineering. Fun fact about Matteo is that he cooks a fantastic steak, picanha, as he is Argentinian, and I guess it should be in his blood. And yeah, then we have Sebastian, who is the chief of the Center of Depression, Anxiety, and Psychotherapy at Unispital Zurich, head of the research group in electrophysiology and prediction, president of the International Pharmaco-EEG Society, probably many more other titles that we have not listed here. But yeah, wow, we're very glad to have both of you guys here. Thank you for joining us.
Thank you also for my side. And Johnny, if I may, I'll shoot it off with one or two questions that I've been dying to ask.
Sure.
So, guys, and I don't know who wants to answer this first, but let's first start maybe with a personal note. So, what got you motivated to actually go down this rabbit hole?
Maybe Sebastian, you can start with this question.
Well, if you mean the rabbit hole is the depression, or do you think the rabbit hole is trying to find the solution?
I guess. Well, so I guess both actually.
Yeah. Well, for me personally, depression is something I am experience every day, of course, because I see the patients. However, maybe I want to make one comment on this video. I mean, it's a really reliable resource, American Psychiatric Association. That's the highest standing organization in psychiatry, as we have it. However, what they did not make clear, they say 5% of people are facing a depression or experiencing a depression. The problem is this is a point prevalence. That means every 20th person has a depression right now. But if you look all of our lifetime, and I now see 1, 2, 3, 4 persons in this chat, there's a high probability that one of us will get a depression within our lifetime, because lifetime prevalence is 20%. That means every 4th to 5th person gets a depression during the life. And I think this again, and there's another fact. I'm a little bit disappointed of the video. It was good that you showed it. However, they did not mention a very specific word, and this is suicide. They said self-harm and thoughts of death. However, you have to remember the main cause of suicidality is depression. And do you know what is the main cause of death in Switzerland for males between 15 and 65 years? It's suicide. So depression in the end is one of the most harming disorders by means of death within the crunch time of life between 15 and 65 years. For females, it's the second largest cause of death in Switzerland. So getting back to your question, what made us diving down into this hole? It's the urgency of the problem. Depression is a really urgent problem. Prevalences are rising. We don't know how we can treat it, as the video has shown. We have many treatment options, and it costs a lot of money. It takes a lot of time to treat depression. So every solution that makes us fight this disorder better and makes us a better manager of the disorder is needed. So this is why we took this trip.
Cool. Thanks a lot, Sebastian.
Wow.
Matteo, and it's mind-boggling actually, and a bit scary. Matteo.
Yes, and my perspective. I mean, when I started on this topic, I didn't know too much about depression, and I didn't know about so much about prevalences and all of this. I was interested in the science and in the technical part. So this is why I started, and when I met and we also started working together, my main motivation was actually like, okay, I find this interesting from a scientific and technical point of view. And as I started getting into the topic, I realized how big the problem actually is, and what the potential for innovation also is, and then my mindset changed also. Then I also realized there's a lot of things that we can do to improve this, and I really saw the potential there.
Thank you so much. But before we go into the solution, maybe if I may ask a few other questions. So, can we say what plays more into depression? Whether it's some chemical imbalance, whether it's the nerve cells not, functioning properly, or personal events? Intuitively, I would have said that people who have experienced traumas in their life, for example, are more likely to face depression. But I don't know. Can you shed some light on this?
Yeah. I mean, you're right. There are different experiences that you could have had in your life that increase the likelihood of getting a depression. However, there are many of such factors, and I guess that every one of us at least has one or two of these factors. Maybe it's not only experiencing traumatic events, but it's also, as we have seen, having some biological vulnerabilities, having stress at work. So there are many factors that can contribute to a depression. I think the main problem at the moment is that what we call depression is defined via symptoms, and the causes might be very different. So that means it's similar to, let's say, back pain. Back pain is not a diagnosis. Back pain is a symptom. So you have pain in your back, but the cause could be someone stick a knife in your back, or you can have an inflammation. It could have been that you just had a traumatic sports accident or something. So there are many causes for back pain, and the same with depression. So depression is just the last mile that we call depression, but the causes are very different. However, we treat depression as it is one unique big disorder, and it is not. It has many different causes, many different phases, and this is where also our, let's say, solution kicks in, because we think that the way we treat depression at the moment is wrong, because we say, well, you have depression, which is a very soft combination of symptoms, as we heard. You feel depressed, you don't have energy, and we all feel every now and then like that. And then we say, okay, you have depression, and here's our treatment. Try this pill. And this is a problem because it's a very specific disease, which a very specific phase for every person who suffers from depression. And we just try to, find a solution that rules them all. And there is no just one solution for all of them. So what we need is try to find out how we can stratify these patients into groups that might have different causes, but more importantly, that might need different treatments. And this is something that we are looking for, finding different subtypes of depression, let's say, where we know we have many treatments, but they don't work in every subject. But let's find out which subject deserves which solution and which treatment. And this is what we want to do.
So is what you're saying that the diagnosis today is not functioning as it could and should, and you're proposing that there are ways to do this better?
Yeah, maybe it's not the diagnosis, but you're right. It's by means of assessing facts is our problem. I think the diagnosis is pretty clear because you can make the diagnosis on the behavioral level. Once you're not able to have joy and enjoy life for 2 weeks, and you have thoughts of suicide and so on, then the depression is clear. The diagnosis is clear. However, what is not clear, what can help you? And to find out facts about that, just imagine if you fall off your bike now and your arm hurts, and you go to the emergency room and you ask the surgeon, my arm is hurting, and he asks you how big is the pain from 1 to 5, and you say 1, then he just gives you a painkiller and you can go home. And you say 3, and he says, okay, you're gonna get a bandage. And if you say 5, he says, oh, come on, we have to do surgery. You will say, well, don't you want to do a CT or some examination of my arm? And of course, yes, you would do an examination of the arm. And now imagine you have a depression and go to the physician, and he just asks you, how do you feel from 1 to 10? And you say 10, and he gives you a specific pill. And you want to say, well, don't you want to look in my head? What's wrong with that? And no one does that. So we treat depression like 100 years ago, let's say 50 years ago. Nothing changed, but there's a lot of progress in what we can measure from the brain, and that's brain waves, or from the other parts of the nervous system. That's the autonomic nervous system. The heart also is governed by the nervous system. So why not take the information we have to make our treatment choices better? And this is something that is lacking in psychiatry. Every other part of the medicine is using all the information they can get: CT scans, MRI scans, ultrasound, whatsoever. But not in psychiatry. And we are here to change this.
Why do you think that has not happened so far? Why is it still being treated like 100 years ago?
Well, on the one side, I think the disorders in psychiatry, they're a little bit more complex. As I said, they have no unique cause, like maybe in neurology. You have disorders that have a very specific cause, and if you can find them and tackle them down, you can treat them. And let's say a stroke, then you have a blood clot in your brain, and this is a stroke, and this is a very specific circumscribed disorder. However, let's say depression, as I said, is much more fuzzy. It's hard to grasp. And on the other side, I think that the modalities we have to assess brain activity, which is the electroencephalogram, for example, that is measuring the brain activity. Fun fact, it was discovered exactly 100 years ago by Hans Berger. But by the way, the information we can get from these brainwaves is very complex. So people are struggling with the ECG that measures the activity of the heart, but this has like 5,000 neurons in the heart. So it's not complex. But you have 80 billion cells in the brain, and we are trying to measure that and make sense of this. So I think that only now, over the years, we developed the right algorithms to handle this kind of information we get from the brain. And it took so many years until we have these algorithms and calculations that put us in the position that we might predict treatment outcome. And we are sure we can, if we get enough data, that you can predict treatment outcome just by measuring brain waves and heart activity, and to tell the people, well, listen, with your biological pattern of brain waves, I think you should opt in for this treatment, or with that pattern, you might opt in for another treatment. And thus, by stratifying treatments, we could improve the way we treat disorders. Maybe what is important in that point is that when we treat depression today, almost 50% of patients do not respond, and they have to change treatment after 2 to 4 weeks. So this is why we think finding the best treatment right away is very important.
And this is very interesting. So what kind of treatments actually exist? I mean, are you referring now primarily to like pharma?
Yep. Oh, nice. So we changed the slide. Yeah, there are many different ways of treating depression. I think depression is one of the disorders we have dozens of treatments. I mean, there are at least 2 dozens of different drugs and drug classes, like selective serotonin reuptake inhibitors, selective serotonin norepinephrine reuptake inhibitors. There is tricyclic antidepressants. There's lithium. So there are many drugs. But there are also many so-called interventional therapies, such as electroconvulsive therapy. You have transcranial magnetic stimulation, where we stimulate the head via a magnetic field and try to make the brain work. There's light therapy. There's psychotherapy. There is sleep deprivation therapy. There is, we see it here now, psychedelics that support the psychotherapy. There's fast-acting agents that you can apply intranasally, which is, for example, ketamine. So we have many different ways to treat depression. What most of them share is it takes time until they take action. So there's no treatment, there's no immediate treatment of depression. And this is why it's so important to find a working treatment right away. So if you start a drug, for example, which in 80% of, or let's say 60% of patients with depression, they receive an antidepressant. However, it takes at least 2 weeks until you can decide that this drug works or not. And so yes, we have many treatments, but we just don't know who will respond to which treatment.
And maybe also to add to that is, so coming back to the example of the back pain, and I think this is a very good example. The diagnosis of back pain, it's you can assess if a patient has back pain. The important question there is then what do you do if somebody has back pain? And today maybe I'm not a back pain expert, but I assume there are several things you can do, and you can also make an examine the back, see what is happening there, and then draw conclusions. But if you would not be able to know anything about the patient who has back pain, you maybe would first, try one treatment for back pain. And if it doesn't work, you maybe try something else. So if you don't know what is happening there, you can only just try different things and guess what might be better for the patient. And just something that I wanted to add from the slide before. So if Joni, yes, here what we can see on the left side is the effectiveness of the different drugs. So this is from a meta-analysis of Stone et al. And the important takeaway here is that you have a lot of different medications, but the effectiveness of everyone is more or less the same. So it is not very clear that one is on average better than the other medication. So there's no real path on today on which medication you should start first, because they all have on average more or less the same effectiveness. So please, Sebastian, also correct me if I'm saying something wrong. You're the expert on this. But yes, I found it very interesting this study.
From what you're saying, basically, right, and also from what I understand from the slide, there is this trial and error way of treating depression or any disorder, mental disorder at the moment, and you're changing that. How are you changing that?
Yes.
Maybe I think would be great to hear what you guys are doing, how you're disrupting the industry, and have a 10-minute pitch.
Sure.
Okay.
Perfect.
So, okay, the pitch. Great.
Exactly.
So
Floor is
you
yours.
you switch the slides and I do the talking and then hand over to Matteo every now and then, or how do we do it?
Absolutely. You can just
Okay,
tell me
great.
next slide and I'll switch. Yes.
Okay. So, welcome. This is the pitch for DeepSci. We want to match the right treatment to the right patient by using our B2B EEG ECG analysis software, and this is how it goes. So, the problem is, and we just talked about that more than 50% of patients that suffer from depression do not respond to first-line treatment. That means that they keep suffering for 2, 3, or even 4 more weeks until they change treatment. And it's not sure if they then respond to the second-line treatment. So 20% of people suffering from depression during a lifetime, and 50% of them not responding first-time treatment. So this is why we need a solution for that. And the solution is we need to find the one treatment that fits the patient. And this means, and this is the so-called stratified psychiatry. That means by means of a brain pattern or of a biological pattern, we can find matching treatments that help to get out of the depression for the patient. And how we do this, maybe we can switch the slide again. This is how the magic goes. Every hospital and many neurologists, psychiatrists, they use the so-called electroencephalogram, the EEG, for recording brain waves for diagnostic purposes. However, nowadays, these brain waves can be used to obtain information about the underlying brain activity and about underlying causes and biomarkers. So DeepSci uses these markers that can be derived from the EEG, from the brain waves, and from also the heart activity. And by applying algorithms that have been proven to predict treatment outcome in dozens of international studies and publications, we provide a report to the treating physician that tells them, the physician and the patient, which treatment option might be best. So this is the way already existing information from brainwaves is calculated into and put into a report that can be used by the psychiatrist and the patient to improve treatment decisions. Okay? So this is our primary business. Maybe, Matteo, you want to take that slide?
Yes. So usually the hospitals, they have an EEG machine in their facilities, and what they can do is make an EEG on their patients, and they then can send us through the cloud the EEG data. We analyze it, and then we provide a report like Sebastian said. So maybe as an example, this is the exact report that they get, and this, the good part of this is that we are able to align the improvement in the treatment with also the profitability of the treatment. This is because the hospitals are incentivized financially to have a high throughput of patients. So that a hospital gets more money if there is 30 patients for one day than 1 patient for 30 days. And this makes sense. And with our technology, we allow this. We allow to increase the throughput of the hospitals, and then the cost of doing our analysis, it pays for itself, and even the hospitals get that profit from it. So yes, this was also very important, for the scalability and the adoption of the technology. Maybe we can continue. Yes, and we not only provide the report, we also collect data, and with this data we can improve the prediction. So we start with existing markers that have a predictive value that allow us to stratify the patient population. We can generate revenue with this, but then we also enables us to have a foot on the doors of the hospitals and collect the data, and we can collect it on an anonymized way, and then with this we can improve the algorithms, and then also get more partners that will work with us. So this is the cycle that we are aiming for. Yes, and we're also very, very happy to say that we are live in Switzerland. So our report is being used on real patients in clinics in Switzerland, mainly in the University Hospital of Zurich, and we have developed more than 650 medical reports. For 2025, we are aiming to expand to scale to other countries as well, and also expand our customer base and help more patients. Yes, and as we also talked before in the introduction, the market is really big, and it's growing. It's a growing market, particularly in the young population. There's more and more people with depression, and so we are focusing mainly on the hospital. So hospitals means where patients stay more than 1 day in that place, and our ideal customer now is our psychiatric hospitals, but then in the future we are also aiming to expand to the ambulant sector as well. So actually we have also ambulant clinics that are working with us, but in the customer acquisition process we are focusing on the hospitals. And yes, here we can see the competition. So in Europe, there's not really another company doing something similar to us. There are some other research groups in universities that are also looking into this. But in the US, there are a few that are starting, and also we have Telemind that have been doing this for a longer time. But Telemind is more focused on the telemedicine sector, and yes, we didn't see much improvements in the science part. Some therapeutics, however, we know them. They are a good company, but they are more focusing on helping on the R&D sector. So and the same with the digital medical experts, and they are very focused on the US as well. I actually don't know exactly what their plans are, but I believe they are not going to come to Europe anytime soon. And yes, we were able to build an incredible team with Sebastian Ulrich, with me. You know us already, but then we also have Enzo Altamiranda. Enzo is doing incredible work with the technology and with the quality. Like we were able to combine a quality lead and a technology lead. And this is very good for us because we are only software and cloud-based. And usually, yes, it is not so easy to find somebody like that. So this is, we're very happy. Also, Chen, she did an incredible job together with Alfredo to implement these biomarkers, to code them. And together with Enzo, we put it into the pipeline that we have today that is very scalable. Yes, okay, maybe here Sebastian is who has the most contacts and has a very good network. Me too. I mean, I know Yoni. This is why we are on this. We are here today, so I think this is great. But also, Sebastian, you can also say something about your network.
Advertisement network. Yes, I mean, I think it's important that we have combined networks. I think tackling such a huge task as fighting depression, is in need of many different networks. I mean, you have the technological expertise, you have a network by means of, other data scientists, statisticians, and so on. I know the experts in the medical field from depression and other psychiatric disorders. We have contacts to different universities. And I think these huge problems, and maybe this is also one problem of mankind to fight these diseases, is that they bring together a plethora of minds and of people who have different skills. And only by combining these skills and these networks, we will be able to advance. And as I said, these problems are so complex that no single person can solve it. I mean, 100 years ago, you could be a famous scientist by just discovering something and doing everything on your own. I think these days are over. Maybe there's one person more outstanding than the other, but in the end, it's a huge team and a huge network that stands behind them. And so this is why I think it's important to combine the universities, the private corporations. And maybe one other remark is, and as I see IPAC here, I also think that the ETH in the technological field, there are many startups. There's it's a big blend of companies and academia. However, in the medical field, and especially in psychiatry, this is something new. I mean, we were called the talking medicine, but so you don't need no technological innovation. But now we have the large language models, we have the brainwaves that you can measure. So now startups and technology is getting into this field of medicine, into psychiatry, and I think this is a huge chance that we have at the moment, and we can use this technological push to change the whole field. And I hope DeepSci is on the wave and will ride the wave, and we will change the way we treat depression. Or as Mick Jagger said, start it up, huh? Okay, yeah, we're going to do that.
Super. Thank you so much, guys. I was just wondering, as you were speaking, so I guess when we look at depression, generally the first problem is for people to actually take action to make themselves better again, right? So I guess some get lost over there already, or yeah.
Well, this is true, but on the other side, so it's so difficult to find a psychiatrist. So to get an appointment is something that is not easy. And then when the people take action, they cannot find a psychiatrist because they are all booked. And this is true. And then in the moment when they are taking action to find help, they just, or if a family member tries to find help, they are all booked. And we need solutions to make it more efficient. Mm-hmm. And this is just what we are doing.
And you're and this was the other thing that really stuck with me, actually. So, measuring the brainwaves, to put it a bit simply, does it really work? I mean, I guess a lot of the listeners will be like, okay, that sounds fancy, it sounds cool, but does it really work? Do you have evidence that it works?
Yes. Yeah. Definitely.
Yes.
So this is something I've been working on all my life. So I started as a physician in 2007, and since then I've been working with the brainwaves, because this was something that caught my eye, that we were able to listen the neurons how they work in the millisecond range. And this is what you can do. You can record the activity of the neurons in the brain in milliseconds, and you can watch them what they're doing. And already a couple of years after the EEG has been discovered, the people realized that there's a very tight relationship between the most prominent patterns in EEG, that is the so-called alpha rhythm. The alpha rhythm, you can imagine, is something like your heartbeat. So it's a ground rhythm of the brain. And every one of us, everyone has a ground rhythm between 8 hertz to 12 hertz. And this is a very prominent wave. You can see it in every EEG. And they started to realize that there's a very tight connection where this brain activity occurs. And from the 1940s, of course, from the last century, to now, things have changed. We now can record with a very higher sampling rate. We can assess with more accuracy the localization of the brain activity. And by using this information and improving it step by step, we have studied patient populations of a couple of hundred patients, like 600 in the iSpot study, several hundreds in the EMBARK study. And all these studies using EEG found out that it is possible to identify patterns that predict treatment outcome, for example, for SSRIs or for SNRIs. So DeepSci is at the moment only using markers that had not only been identified, but that have been replicated in independent studies. So we have a very high level of so-called evidence, evidence-based medicine, and we only use these markers in our report to be sure that our report helps to improve treatment. So yes. we have
for example, here,
use it.
Yes. So here in our report, we cite also, and we also put all the references what we are using to base our prediction on. Like what we do is a systematic review from the literature, and then we assess, what is the effect size and the prediction of the different, and also the evidence level of the different markers. Yeah, so this is, and the markers that we implemented in our pipeline, they have the highest evidence level of what there is in the literature. And then maybe just going back 1 second. So this is one case where we use the vigilance regulation as a marker for the prediction of the response to ketamine. Ketamine is a very expensive treatment, and the thing is, here we identified the marker in one data set, we validated in another data set, and we validated it again in a complete separated data set as well. So this is on a 3-level data set population that we have been able to replicate it.
So to put this in very plain language, so different patients will respond differently to the ketamine therapy, and with the data analysis that you do, you'll be able to determine how positively a patient will respond to this.
Yeah.
Yes.
I mean, maybe not how positively, but we have like some kind of probability. So it's not like a 100%. When we say, well, you're less likely to respond to ketamine, you still have a chance to respond to it. And if you say you're very it's highly likely that you respond to ketamine, you still might be a non-responder. But we improve the proportion of patients that get the right treatment. So it's not a 100% solution, but we improve the chances that you have. And in the case of ketamine, it's quite easy. Let's say, maybe you know what ketamine is. Ketamine is an anesthetic drug. that lowers your vigilance. You almost sleep, you get dreamlike states. And what we measure is the EEG vigilance. And we can predict if you have a very high vigilance, which is very common in depression, you just cannot shut down, you cannot sleep, you're very high vigilant, then you're very likely to respond to ketamine. And if you already are in a more drowsy state, more fatigue state, which also sometimes is the case in depression, you're not likely to respond to an anesthetic drug. And the beauty about it is that we can measure these brain states using the EEG, and we can measure that with a very high accuracy. And by using those measures, we could stratify into, well, ketamine is very expensive. It costs like 600 to 1,000 francs per application, and you have to do that twice a week. And we can say, well, you're very likely to respond. Let's try it. And you have a pattern that tells us it's unlikely you're going to respond. Maybe we try something else first. So this is how it works.
Super. Thank you, Sebastian. And I guess the patients that you see, you've been using your technology with regularly. And can you maybe provide an example of to make it more kind of tangible of a patient who came to you and you were able to help, especially with this?
Well, maybe two cases. The very first case is very basic. Let's say you're a young 22-year-old student experiencing depression for the very first time. You're a little bit reluctant to take medication because you've heard all this social media stuff about antidepressants. You gain body weight and so on. So you're a little bit reluctant. However, your psychiatrist tells you, well, if you really want to continue with your studies, maybe it's better to take antidepressant pills so you get out of depression earlier. And then we can measure the EEG and get a report that tells us which of the most prescribed drugs against depression might help you benefit from it. And this is when the patients say, okay, it's good. It's not only the psychiatrist that sits in front of me and tells you, take a drug, but they measure something, they get a report, and they tell me that an SSRI might be the best choice, and then they take it.
It's based on data, basically.
Based on data. And we have many patients that are not very willing to take drugs, but if they have some objective information that underpins what the doctor says, then they say, okay, let's have a try. And this is a very good point.
Sebastian, you as a psychiatrist or doctor yourself, would you recommend these patients to listen more to the data or to the doctor?
No, it's a so-called shared decision-making process. I think it's both. Sometimes I tell them, well, I use a report just to say, well, listen, this is biology. Let's have a try. And the report is more or less just to support, to push them into a good therapy. And sometimes it's really like the patient is asking questions, what does that mean? And what about the vigilance and so on? So it's two sides of a coin. You can use it and say, well, this is the science, take it. And sometimes it's better to talk to him. And sometimes it's like the report says you have to go that way. And the patient says, no, I tried that 10 years ago. I don't want to use the drug anymore. And then you say, okay, let's go to the next kind of treatment. So it's not a one hit. It's just a story we tell and the road we walk together. And maybe the second,
sorry. Yes, sorry. And that also it's very important that the doctor also makes the decision what to give to the patient, because the safety of the medication is also very important. So we are not looking too much into that, and that's responsibility of the doctor to assess, if the medication is adequate for that patient. So we are also not taking anything away from the doctor. We are just giving more tools, so that the psychiatrist can make better decisions than what they have been doing before.
Okay, cool. Would you guys be happy to share with our community on Discord some literature on the evidence, it working, peer-reviewed studies or what have you, just so people can dig into this if they want?
Yeah, sure.
Cool. And would you also be, sorry, and this is now out of just interest, something I would want to read into, would you be able to give an overview of potential treatment paths? Just so one can see because prior to this discussion, for me, it was like you you take an antidepressant pill, and they're all very similar, and you take it or you don't. But it seems it's a lot more complicated than that. So if you'd be happy to share that, we'd be very grateful.
Sure.
Thank you. And then maybe on the business side, a question. So I've invested in a startup some years ago who also had part of the strategy to work with hospitals, and the technology from a technological point of view was tremendously appealing. And the problem that they had is to get the hospitals to change their internal processes. So this was a very, very hard battle to get them to do this. Have you seen this problem yourself? And if yes, how do you plan to address it?
I mean, it's a problem. The grown structures in hospitals, it's hard to change because they underlie a lot of regulation, and and physicians themselves are a little bit, stubborn. But still, we can do it. I think maybe what we discover, it's not the hospitals themselves that have structures that hinder us from advancing. I think it's the whole medical system that is based on analog and non-digital solutions. So the same as we have with all these apps that we now have for depression and so on, it's very hard to get through the regulation processes. It's very hard to find, we have in Switzerland, we have this TARMED system that allows you to charge for your services. And all these systems are based on old-fashioned medicine. So digital solutions have no place there. So no one knows if you can charge for that or if you cannot charge for that, if you can get money, which regulation applies for you. So I think the hospitals themselves, they would be ready. If you tell them, well, you have to go this way and then you can get your money from this and from that insurance there, that would be easy. The bigger problem is the surrounding environment and the regulation.
A follow-up on the regulation part, because I couldn't help but notice, right? I see your roadmap here, and you say that Q1 2025 you have approval and rollout in UK, and then approval and rollout in EU and US. Well, this is a topic I'm very it's very close to my heart. Why are you going to UK first?
Yes, I'm the person to answer that question. So in the UK, we are a medical device class 1. So they have a different set of regulations, or maybe to be more specific, the regulations of the UK are the old regulation of the EU. They didn't update their regulations. And then it's much easier for us in our case to go there, because there we are a medical device class 1 and we can self-certify. In the case of the EU, we have to go through the notified body, and we need to get much more audits in. So we are in the process of doing that. We have been, there are two parts of the process. One is the quality management system. The other one is the technical documentation. Everything of the quality management system, we have been audited, and we are also certified ISO 13485. So everything there, it's going smoothly. In the technical documentation also, but now we are in the process of submitting the technical documentation. And the waiting list for the review of the technical documentation is like at least 6 months. Mm-hmm. So we are entering now the waiting list, and then we are going to get a spot maybe in 6 months from now. So this is the main reason why the UK, yes, we get the approvals first in the UK. And I also wanted to add something to the question of Roman before. In our case, there's no need of investment at front in the hospital. So the hospital can, and something that we also notice is that within the hospital, and for example, in the university hospital, the people using it inside it kept increasing. At the beginning, it was a few, and with time, they use it more and more. So there's also like an internal adoption curve in the hospital, and they don't need to invest up front on almost anything. So this is one good way to enter the space, because there's very low risk for the hospitals. And something additional is that the psychiatrists usually have a lot of freedom, to decide on things.
And
so this is
since we're on the topic of investments already, I think would be important to mention that you guys, similar to every other startup that is coming on our podcasts or stream, you're also fundraising, right? I think we didn't mention how much you're raising.
Yes.
And for what? Yeah.
Yes.
Yes, exactly. So we will start next semester with the fundraising, and we are aiming to raise 1.5 million.
And this is the first time. And what do you plan to use that 1.5 million for?
Yeah, so it is for the expansion to the other countries. This is the main reason for customer acquisition. Now we are in a spot that we are very scalable. We have a great product. Like in the last couple of months, we have been getting a lot of feedback on the reports. We were able to optimize it to have a very good product market fit. And as from next semester, we are in a spot to really be able to grow and to expand within Switzerland, but also to the UK, and by the end of the year also to other countries in the EU. So it's mainly for the expansion.
Okay, cool. And one other question, if I may. So the 650 medical reports that you've issued, how many of them have you been able to charge on?
A few, not so many. But the reality is also we have been more interested in getting the good product market fit and to learn from our customers than really, try to make a lot of money from it. So now we are in a spot where we want really to, where we have learned, and now we have to start getting the revenues in. But sometimes, we were also not sure how to. Yes, so there is a learning process that is much easier if you are not charging upfront.
Of course, yes.
Nothing up.
Cool.
Maybe just one point for that. So also in the medical field, I think it would be better for us not to charge on the patient, because this always is a sign of, well, this seems to be something that the physician is selling me, so there's no proof of its evidence. Only if the insurances pay for it, it's regarded to be safe. So we have to find a way to get into this official insurance system, and this is a long road too. Just to add to that, and yeah.
But and there's some complexity. So, for example, now we found a way on also charging the insurances. But yes, there was also part of the learning process, and yes, exactly. And in the future, we are going to be able to charge more to the insurances what we are able to do today.
That's understood. And so, I mean, clearly, so you're looking for funding to continue your journey, a very important one. On the other hand, I'm speaking here on behalf of our members. Maybe, you will benefit from their support in other ways as well. Where you just mentioned insurance. I don't know if someone is, in that field, could they help you? Maybe there's other ways to support you in terms of raising awareness. So do you want to maybe share a few words on how we can support DeepSci, maybe beyond the financial part? Needless to say, the financial part being, one of the most important ones.
Well, one thing that is we are looking for somebody who can help us also with the business development. Like we are looking for new talents that can help us on to recruit. Yes, this is one very important part. Also, if somebody has connection with the insurances, currently we are working in Switzerland with the CSS. So that's one of the most important insurances in Switzerland, and they are supporting us here. But if anybody knows in the UK or other countries, that would help out a lot, to understand the landscape of those other countries. Also, if somebody has connections with hospitals, with the clinics, that also would be great. And if somebody is developing new drugs, we can also help them stratify the patient population at the clinical trial level. So this is also one advantage. Our main focus is on the clinical and medical sector, but most of our current revenues were from pharmaceutical companies or other companies developing treatments that came to us for asking for the EEG analysis for their clinical trials. So maybe if somebody is also interested in that, we can also help with that.
I think it's good to hear that you have industry leaders supporting you financially, but not just financially, also with their time and networks. Depression is obviously a huge problem. 20%, if I recall correctly, of the population will experience depression at one point in their life. That's scary as hell. I thank you, obviously, for trying to help solve this problem. Maybe in case just somebody in this call or somebody, in their in their network is suffering from depression and not taking action. Sebastian, what do you recommend them to do?
Well, as you said, it's hard to recognize that yourself have depression. First thing is open up to your surrounding, talk to your partner, talk to your friends, and so on. If you get more signs that they're having depression, then go to a professional. You can talk to your general practitioner. You can also go to a specialist, but just go into the medical system and try to share your experiences and try to tell them how you feel. And I'm sure once you're in the system, you will receive the help you need to get out of depression. The most important thing, don't stop communicating, share your thoughts and feelings and express them to your environment. That's important.
Awesome. Thank you so much, Sebastian, Matteo, for our first Catalyst Conversations. We wish you all the best. We'll be following you very closely and watching your success.
Thanks for the invitation. Thanks, Roman. Thanks, Johnny.